So we are going to be finishing Chapter 4, Nutrition During Pregnancy today, to complete our last lecture before you take the online exam. One note is that we have extended the online exam to February 15th at 11:59 p.m. in order to accommodate for the changes with Dr. Colby having the flu and me not being able to be on campus. If you have any questions or any concerns about this material that's being presented, please feel free to email myself or Dr. Colby to ask questions. Seeing some people have already taken the exam and done fairly well at it, so I wouldn't be too overly concerned. Also, I uploaded the YouTube link for the PowerPoint presentation that I did during the study session the other day. It is a review of probably the most important slides that you really need to know the information on, as well as I shared a Kahoot link. The Kahoot has about 45 questions that are potential questions on your exam. Your exam is 50 questions. You have 80 minutes to complete it. And once again, you have until February 15th at 11:59 p.m. You should be able to see your grade instantly, but you will not be able to view the correct answers from the exam until February 16th. All right, so let's finish up with the Chapter 4, Nutrition During Pregnancy slides. So picking up from the energy and nutrient needs during pregnancy that Dr. Colby discussed in class last Tuesday, some of the needs for vitamins and minerals do change during pregnancy. Folate is one of the most important, with an inadequate intake being associated with anemia and reduced fetal growth. Now, folate itself helps with metabolic reactions, thus deficiencies can lead to congenital abnormalities. Typically, a doctor or an MD would assess this by serum and red blood cell folate levels. Your most common dietary sources are vegetables and fruits. Just remember those dark green leafy vegetables. Now, the recommended intake is 600 micrograms. However, we know that it can go up to 1,000 micrograms or 1 milligram of folate daily for pregnant women and be safe. But the base minimum that must be had is 400 micrograms. It's very important to remember that as long as they're getting in that base minimum at that 400 micrograms, it's adequate, but it is recommended that they take just a little bit more. Choline is a B-complex vitamin. Current RDA for all healthy people, or practically all healthy people, is 450 milligrams. This is the same for pregnancy as well. However, we know that many of the women in childbearing years are actually not getting the adequate amount of choline that they need. And choline is actually not included in most prenatal supplements. Remember, choline, you're talking about meat products, eggs, things like that. Vitamin A is needed for cell differentiation. Now, vitamin A deficiencies are not of massive concern in developed countries anymore, but in developing countries, we still have massive concerns about vitamin A deficiency in both women and children. Now, vitamin D supports fetal growth. We know that it also goes with calcium and magnesium for bone development. However, the vitamin D inadequacy during pregnancy is common. A study in Canada of 206 women found that the approximate prevalence of vitamin D deficiency was about 35%. So we do want to make sure that women are getting enough vitamin D. Calcium is needed for fetal skeletal mineralization in maternal bones. One interesting thing about calcium is that the needs for calcium change during pregnancy. And so the further along in pregnancy that women get, there is an additional requirement for calcium. And that's partially obtained with increased absorption and release of calcium from the bone. However, we do need to encourage our moms to be drinking at least 3 cups of milk or calcium-fortified soy milk in order to get adequate sources of calcium in their diet daily. Fluoride is actually not recommended as a supplement because there are limited amounts of fluoride that are actually cross the placenta to the child, and research has shown us that increasing fluoride amounts in mom does not decrease a baby's risk for dental caries later in life. So iron is very, very important. Our needs for iron actually increase substantially and for more reasons than one. So we need about 300 milligrams daily for the fetus and the placenta. You actually lose about 250 milligrams at delivery, and you need about another 450 milligrams due to the increase in blood volume. So pregnant women require about 1,000 milligrams or a gram of additional iron for pregnancy. Now, it's important to note that iron deficiency is the most common nutrient deficiency disease in the world. Overall rates of iron deficiency are lowest in the first trimester. They increase more in the second trimester, and they peak in the third trimester at 28.4%. And we also see an increased rate of iron deficiency in women that are of lower income or served by the WIC program. So iron deficiency is marked by depleted iron stores. A lot of times you'll see weakness, fatigue, short attention span, poor appetite, increased susceptibility to infection and irritability. Now, further than that, you have iron deficiency anemia, which is actually diagnosed through some of those biochemical markers, such as low hemoglobin. So you're going to actually see the same symptoms as iron deficiency, plus a lot of times you will also see arrhythmias, paleness, and exhaustion. Now, the problem with iron deficiency anemia is there's an early pregnancy risk, of preterm delivery, and low birth weight for the fetus. And even in the fetus later in life, sometimes we see lower scores on intelligence, language, gross motor, and attention tests. So what do we do for iron supplementation in pregnancy? We normally recommend at least 30 milligrams of iron supplement daily. Typically can be obtained through a prenatal supplement. However, those with iron deficiency anemia a lot of times will be recommended to take 60 to 180 milligrams a day, depending upon absorption and other diet needs. So here is the CDC's age-specific cutoffs for anemia in pregnancy. In general, though, by trimester, hemoglobin levels that are indicative of iron deficiency anemia, we're looking at less than 11 grams per deciliter in the first and third trimesters, and less than 10.5 grams per deciliter in the second trimester. So that's really that point that you would diagnose with iron deficiency anemia and up the supplementation. So iodine, we know iodine is required for thyroid function and energy production, as well as fetal brain development. We also know that the best source of iodine in the current American diet is iodized salt. Most women that consume iodized salt are typically fine. They don't need to supplement with additional iodine. But just important to remember that fish, shellfish, seaweed, and some types of tea actually help provide iodine. Sodium is critical to maintaining the body's water balance, especially in pregnancy when we have an increase in blood volume and an increased need for hydration. The problem is previously we thought that sodium restriction was an important part of pregnancy to reduce risk for hypertension or gestational diabetes. However, we now know that sodium restriction is just not indicated in normal pregnancy. It's not going to control edema. It's not going to decrease risk of high blood pressure. It actually can create further issues to be on sodium restriction. So in general, we advise to consume salt to taste. So just salting on the table, eating a lot of high processed foods, unless there's a medical condition related to salt intake, which we'll talk about later in chapter 5. But in general, we're not going to have sodium restriction diets for just a healthy pregnant woman. So there are some bioactive components in food that we've talked about in the course so far, phytochemicals, antioxidant pigments, things like that. And we have to remember that normal pregnancy is a pro-oxidative state. So we have an increased need for antioxidants. Many plant pigments act as antioxidants and help protect fetal DNA from damage due to that increased oxidative stress that is sometimes produced during pregnancy. They're not considered essential nutrients, but they do influence health. So increasing plant foods, making sure they get 5 or more servings of fruits and vegetables daily, a variety of colors can help ensure that they're getting in adequate phytochemicals and antioxidants. Other things, coffee, caffeine. Sometimes you hear coffee and caffeine are really negative things during pregnancy or can be tolerated. The most recent research we have is that moderate amounts of intake, such as 3 cups daily, we're talking about standard coffee, non-espresso, do not appear to pose a risk for mom. However, the need for water is really, really increased. So we're talking about the average consumption being 9 cups of fluid per day, and that really being the bare minimum of what mom would want to do. Also, a lot of times it's met by increased levels of thirst, just the body increasing blood volumes and the mother feeling thirsty a little bit more frequently. So some things that might affect the maternal diet during pregnancy. A lot of taste and smell changes occur during pregnancy. Certain meats, certain cheeses, certain external environment smells can actually smell more prolific to the mother, and so they may not want to eat certain substances. Not too concerning. As long as they're getting in an adequate diet in other ways, then they should be okay, but just remembering that when creating individualized meal plans. One important thing to think about is pica. Now, pica is actually classified as an eating disorder, and it's when mother eats non-food substances. It actually affects over half of pregnant women in some locations in the southern part of the United States, more commonly in non-Hispanic Black Americans than other groups. So some examples of pica, actually even eating ice is considered pica. We hear a lot about cornstarch or laundry detergent, mud sometimes with high clay content. A lot of times there's not a reason for that particular need to eat those substances, but we have to be concerned about nutritional deficiencies that may occur when they're replacing these non-food substances with nutrient-based food substances. And just cultural considerations, just understanding that different cultures have different food preferences, specifically for mothers and children, and thinking about the fact that we need to change our dietary recommendations and offer those individualized meal plans based on those needs. So in general, healthy dietary patterns for pregnancy, we talk about that increased caloric intake, increased nutrient intake, and making good food choices. Getting in sufficient fiber, hydration, folic acid, and excluding alcohol. And most importantly, it has to be satisfying and enjoyable to eat for the pregnant mother. Obviously, we can't get good nutrition if we don't eat it. So it's really important that we encourage the mother to eat what sounds good to her. One particular concern is vegetarian diets in pregnancy. Typically not a big concern with a well-planned diet. We do have to be careful with vitamins B12 and D, calcium, iron, which is already, like we said, that more common deficiency, zinc, and the omega-3 fatty acids. And even more restrictive with the vegan diets, we have to really, really watch this B12 and iron intake. So dietary supplements during pregnancy. Commonly you'll be asked, do I really need a prenatal? Is a multivitamin something I need to be taking? In general, for pregnant women, we say the same thing we do with healthy people, that your nutrient needs should be met with a well-balanced diet. Iron being the exception, because the iron deficiency is so prevalent, it is sometimes recommended to do that 30 milligrams of iron daily. The American College of Obstetricians and Gynecology and the Institute of Medicine actually do not recommend the routine use of multivitamin and supplements during pregnancy. But rather, it's recommended only if there is a need that indicates it, such as iron deficiency anemia. Another thing you commonly hear is herbal remedies. They're generally regarded as safe, and health professionals will generally say helpful, safe, and gentle. However, 1/3 of commonly used herbal supplements have been actually deemed unsafe for use by pregnant women. So discussing with your doctor about what herbal supplements you are actually taking would be pretty imperative. Here are some of these herbs to avoid during pregnancy. Just a few to point out here. The black cohosh actually can increase uterine contractions starting labor. So big one to stay away from. The blue cohosh as well. The ginseng is actually one of the most commonly used herbs in the world, and it's been found to cause fetal rat malformations while they're in womb. So foodborne illnesses, mothers with a compromised immune system, so typically pregnant women that are naturally compromised anyways, typically we have to worry about that increased risk for foodborne illness, one of which being listeria. Listeria is actually associated with spontaneous abortion and stillbirth in 1/3 of fetuses. So with this, we want to make sure our pregnant women are not eating raw or smoked fish, oysters, unpasteurized or soft cheeses, raw or uncooked meat, or unpasteurized milk. Also, things that we don't commonly think of with that are deli meats, hot dogs, and other processed meats, making sure they're stored correctly, and possibly even heated completely. The other is toxoplasma. So this is a protozoan that can actually be transferred from mother to fetus, can cause mental retardation, blindness, seizures, and death. We can get this from raw and undercooked meats, the surface of fruits and vegetables, and the most prominent being cat litter. So we're making sure to educate our mothers not to be changing the litter box. So how do we assess the nutritional status during pregnancy? Well, the first thing we do is a dietary assessment. So we're talking about doing that 24-hour food recall or a food record, discussing supplements, prenatals with them, and tracking weight gain. We also need to be looking at some nutritional biomarkers such as iron and other nutrients and assessing states of deficiency. So one thing is exercise. I'm sure it's common knowledge now that women who exercise regularly tend to feel a little bit healthier, often have shorter labors, and they also reduce the risk of developing gestational diabetes, pregnancy-induced hypertension, and excessive weight gain. One thing that has not been commonly thought of, though, is whether moderate or vigorous exercise is harmful. The biggest piece of recommendation that we can give our pregnant women is to talk to their doctor, first and foremost. But chances are, if they were engaging in moderate to vigorous physical activity prior to pregnancy, it's typically deemed as safe unless doctor says no. So some common health problems that may come up during pregnancy that may affect nutrition status that you should be aware of: nausea and vomiting. Now, nausea occurs in about 8 to 10 pregnancies, and vomiting in about half of pregnancies. Normally it starts around week 5, and generally it actually disappears by the end of the first trimester. And in fact, it's so common that it's now considered to just be a normal part of pregnancy. However, in about 1 in 5 pregnant women, nausea and vomiting continue throughout the entire pregnancy. And that's where we're talking about this hyperemesis gravidarum. And how do we manage that? We want to make sure they're continuing to gain weight appropriately, avoiding those trigger odors and foods that may make them more sick, and supporting well-tolerated foods. Some dietary supplements we can discuss are vitamin B6 and ginger. Also, some frequent concerns are heartburn. So similar to the same way that we manage heartburn for the healthy adult, we suggest small meals, not to go to bed with a full stomach, possibly sitting at that 45-degree angle to prevent the reflux, and avoiding those trigger foods such as spicy or high-fat foods that make heartburn worse. Constipation is another common problem, and we're really talking about prevention there. So consuming enough dietary fiber, approximately 30 grams per day, drinking water along with the fiber, and not relying on laxatives. And so here are some nutrition programs that have been found to have risk reduction in pregnancy. The Montreal Diet Dispensary actually was the model that was used to develop the WIC program, very similar, where they had a multidisciplinary team, primarily with dietitians, having mothers come in and do individualized dietary assessments. What they saw was fewer low birth weight infants and lower rates of perinatal mortality. And then our country's WIC program, which provides nutritional assessment, education, and counseling, and we see similar improved outcomes. So that concludes the Chapter 4 PowerPoint presentation. Let's move on to Chapter 5. So in Chapter 5, we're going to be talking about the conditions that may occur during pregnancy and how nutritional interventions may help. So it's important to note that a vast majority of pregnancies actually proceed very normally, resulting in the delivery of a healthy newborn. However, there are some primary health conditions that may occur with nutrition playing a large role in their etiology or their management. So one of the biggest being obesity in pregnancy. I'm sure this is not surprising for most of you. As we know, the majority of our country is overweight or obese. So dealing with obesity before or during pregnancy is not an uncommon thing. However, it can produce unfavorable genetic, hormonal, and metabolic conditions. Further, the prevalence of gestational diabetes and pregnancy-induced hypertension actually increase due to the increased rates of obesity. And we know that it can affect maternal health, fetal growth, and development, and later outcomes of the mother and the child. We definitely see some metabolic changes in the mother's body, increased blood glucose levels, blood concentration of insulin, insulin resistance, higher blood pressures, higher C-reactive protein levels. So what do we do with a patient that is overweight or obese when they come in for a nutritional assessment? Well, some of the recommendations and interventions that are appropriate is we're wanting to make sure that they're meeting their nutrient needs. They're consuming a variety of basic foods and participating in physical activity. And we specifically may want to be looking at any behavior modification that needs to occur related to food. And lastly, it's very important to remember that we need them to maintain appropriate rates of weight gain. Women who enter pregnancy obese are much more likely to gain unhealthy weight during pregnancy compared to normal weight women, and then retain more of that weight gained after pregnancy. And the biggest thing to take away is weight loss during pregnancy is not recommended. So because of the fact that the use of bariatric surgery has increased so dramatically over the past 2 decades, we do have to wonder about patients that have undergone bariatric surgery previous to pregnancy. And typically we're actually seeing that in about half the individuals who undergo bariatric surgery are women of childbearing age, so we do have to be cognizant of that. We know that with bariatric surgery, the weight is rapidly lost due to limited food intake, fat malabsorption, decreased appetite, and Dunning syndrome. And also there is a deficiency of many of the nutrient stores that are critical for pregnancy, such as vitamin D, B12, folate, iron, and calcium. And actually, the maternal and neonatal health outcomes in women who have had the bariatric surgery tend to be fairly acceptable as long as we maintain their adequate nutrition. So what are we doing? We are assessing their dietary intake, assessing supplements, biomarkers, all the things that we would normally do in a normal pregnancy. We also definitely want to take a look at weight gain though, and we want to take a look at any gastrointestinal symptoms that may be occurring. It is important to note that nutrient deficiencies or differences may vary depending upon the type of bariatric surgery performed. So one good example that the book gives is thinking about the lap band surgery. And with the lap band surgery, the band is placed to make the stomach smaller. In some pregnancies, they will actually adjust and provide a little bit more room to help regulate food intake and weight gain. Okay, so we're getting to a very important disorder within pregnancy. One of the most common, the hypertensive disorders of pregnancy. It affects about 5 to 10% of pregnancies, and the consequences can be very severe, such as stillbirths, fetal and newborn deaths, and other adverse conditions. However, a lot of times we don't really know why pregnancy-induced hypertension actually happens. We do know that there's a possibility of having environmental factors, inherited genetic traits, specifically with preeclampsia, but we're not exactly sure always why it develops. Now, in general, all the hypertensive disorders of pregnancy can be related to actually chronic inflammation, oxidative stress, and damage to the endothelium of blood vessels. And so sometimes you'll see that impaired blood flow, increased tendency to clot, and plaque formation. So all very serious things. Now, there are 4 hypertensive disorders of pregnancy that are important for you to know. The first being chronic hypertension. So with chronic hypertension, typically that's where we see high blood pressure prior to pregnancy, or if it's diagnosed before 20 weeks. It happens to about 3% of pregnant women, and it's most common with those who are non-Hispanic Black Americans, obese, over 35 years of age, or potentially who have had a prior pregnancy with high blood pressure. They are also at risk, higher risk for developing preeclampsia later in the pregnancy. So our nutritional interventions in general is these diets should be closely monitored to ensure that they're getting that adequacy, variety, and balance in their diet, and also they're not consuming too much sodium. This might be one of those instances where a reduction in sodium, depending upon how much processed food they're eating, might be recommended. The second hypertensive disorder is